Mr. Asghar Ali Wain, and he is a clinical director and ED consultant at Darren Valley Hospital, Dartford, and he is going to discuss with us the role of point of care testing in A&E, a literature review.
Thank you. Mr. Chairman, the eminent panel members, guest speakers, and the rest of the audience. I'm going to talk about the point of care testing in the emergency department, and time permitting, we'll talk about literature review as well. Yeah. It has been a very good occasion where we have got lots of people from all over the world, and we have exchanged our views and the experience in the life. I was working in 1992-93 with the Professor of Westman, who was here, I think earlier this morning, and I was the medical officer in in Mayo Hospital, Lahore, in the Institute of Orthopedic Medicine. And he said one thing I still remember, and he said one day, I'm not sure what your experience is, obviously it was a brief experience. Is a very good surgeon and a very good person, and he said one, which I still remember. He said, and it is a statement from Hazrat Ali radiallahu anhu, and he says, everything has a charity. Like the money, the charity is that you share the money with other people, and there is a charity for the knowledge or the ilm you have, which is that you share. And I think that was a very good example. So returning to I work, as I said earlier, in emergency department. This is the place I work. I'm sure the most of the people who work in UK know about the Kent. Kent is called the Garden of the England. So it's a beautiful place. It's not that cold if compared to North. So usually, if you are a gardener, you can grow lots of things. And that might tell you what I do. From 1999 onward, I'm working in the emergency medicine. So, and as a consultant from 2003, so I think there's a reasonable experience working in the A&E. I'm working in this hospital from last 9 years. And that is what I do. And we face the challenges every day. The working in the A&E department, and the audience from the UK will understand that in the A&E, when you go in the A&E, you receive the patient coming in a stream, and there is never a dull or a quiet moment in the A&E. I give sometimes an example that it is like an accelerator where the patients are coming. In my hospital, we see around 275 to 356 patients per day, up to 90 ambulances, and sometimes 5 to 6 ambulances can arrive in the same hours. And the majority of us will be aware that we have got what we call the clinical quality indicators. And one of the clinical quality indicators in the ED, or related to the emergency department, is the 4-hour target, but I would call it a 4-hour standard. The 4-hour standard is that when the patient presents to the ED, it came around I think when the Labour government came, the first Labour government came, where it started, it used to be that you have to see, when it initially started, any patient presenting to A&E within 4 hours, it has to be 100%. So when it was presented to the government and the people talked about it, you say that is madness. You can't in the A&E department and the setting we have. So they reduced to 98%, which remained as 98%. But when the first Conservative government came, they changed it, and they changed it to 95%. So we, at the minute, any patient who lands into the A&E department should be seen, disposed of from the A&E department within 4 hours. Now, it has its own advantages and obviously its own issues, and we'll talk about it. There's a common term used in the A&E department, which is the exit block. So there are lots of exit block, but we'll talk about one exit block, which is the lab investigation. Obviously, we'll all have the experience. My understanding is that in the A&E department, there are lots of patients for which the decision will depend on the outcome of their blood test. Now, majority of the tests we will get within an hour, but the D-dimer or the TROPS may take up to 2 hours. So you're waiting, and if you have to repeat it, obviously these patients are going to be problematic. And we'll look at it if there are solutions, how we can deal with it. So what is the point of care testing? Now, these are the tests which can be done by the bedside of the patient. And if I ask, they do not require any permanent or dedicated space or the lab. So if I ask the audience that what in their opinion was the first point of care test in the history of the medical world, anyone, any guess? So the first time in 17, sorry? You are nearly right. So the first time it was in around 1790 that one of the doctor thought, and rather he desired, he wished, that if there was a test he could do, especially the urine, because there was no way to get the blood or all these things out or any other invasive investigation. So he thought that if there was a test. It was around 1840 when the first time they started boiling the urine, and they started noticing that there was proteins and the residues. But the papers and strips, they came down around 1960. And I remember when I was in the school years, if you go to a doctor and he has to do a glucose test, it may be different here, but in Pakistan, they used to do the Benedict's reagent. They blew the copper sulfate reagent, and they will boil in a test tube, and you look the urine and all this content squirting out, because I did a bit of attachment, and then the color will change. Okay, so we have to speed up. Yeah, okay. So this is the long history we talked about. So what were the drivers? So obviously we were looking for the new opportunities. Could we optimize the process, speed up the process? And with the time, there was a change in the mind that you could do certain tests outside. This is some of the figures, and if you look at the emergency admissions, 5.4 million emergency admission, 60 million people attending the A&E department in UK. And it is rising as you follow the years, the numbers, and the 85 plus number is at the top. So the number attending, they are increasing. We have the 4-hour target we talk about. I said it's target, and it starts as soon as the patient lands in the A&E department. So we have to follow it. It is said that the 4-hour target, if you breach it, or if the longer the patient stays, it affects the mortality and the safety and the outcome of the patient. It has been proved in different studies. We have the exit blocks, and I would the exit blocks for the BMSA. There are lots of exit blocks, but one of the most important, which we were talking about, the delay in the diagnostic services. So why we need the point of care test? Because it reduces the steps, speeds up the process, it reduces the therapeutic turnaround time, and they all have been produced in different studies. It reduces the mortality, overcrowding in the A&E, helps to meet the 4-hour target. On top, it reduces the admissions. We can do, and I've done the experience where you can take the blood and do the test, and you have the result of the TROP or the D-dimer within 15 minutes once you start. So these are the different tests available at the minute. There's a long list of it. We know that the urine and the ABG are the commonest, but lots of tests are available, and the important one will be the dipsticks, the bedside monitoring glucose, ABG, VBGs, cardiac markers, D-dimers. We all do the toxicology, lactate. They all help us to speed up. Not to mention of the pulse oximetry and portable ultrasonography, which is also considered as a point of care testing. And these are the tests which are developing in the future. Some are relevant to the ED and to some other specialty. The commonest which we use is for the acute coronary syndrome. So acute coronary syndrome, and we can do the TROP-I or TROP-T, whichever we feel. It helps to save time. It may not save the money, but if you look at the, if you include the time saved and the admission avoided, it definitely saved the money. And there have been different studies, and all support that it is reliable. Obviously, you have to. There is some person who will be looking after these machines. Will have a coordination with the lab, and after every 10 tests, one test will be sent to the lab to calibrate the machine. We do the D-dimer, and for the diagnosis of a DVT and PE with a low well scoring, we can rule out. We always do the lactate for the severe sepsis. Coags can be done, and for the stroke, the thrombolysis can be speeded up. So there are challenges. There is a training, there is a calibration, quality control, and if I say politely, the biggest enemy in the progress is your own lab, because you are taking business from them, and they do not encourage that. But as far as the A&E is concerned, if we are looking for reduce the overcrowding in the A&E and reduce the admission rate, this is the way forward. Thank you.
Thank you.